At Wellframe, we're applying technology-enabled care redesign to make what works in healthcare more appealing and more efficient. So I'm an epidemiologist by training. I focused on the relationship between lifestyle behavior and cardiovascular disease, and have since been using technology to try to close the gap between what we know and what people do. Trishan, our CMO, who's here today, was an internist who ran a primary care practice before coming to Harvard and MIT to use mobile technology for clinical decision support and also data mining. We're working with 2 computer scientists from MIT who have a strong passion to applying their skills to improve healthcare. Enough about us. I want to introduce you to Bob. Bob just had a heart attack. He received world-class care to unblock his arteries, and now he's home. And like many others like him, he feels anxious, he feels scared, and he feels uncertain about what to do. And he's looking for guidance to help him make major life changes and to get back on track. Thankfully, as many of you know, there's a solution for Bob, a structured clinical program called cardiac rehab that requires that Bob goes to clinic 3 days a week for 2 to 3 months, where he does supervised exercise and gets education on everything known to prevent another heart attack. Cardiac rehab has been shown to lower readmissions, to lower risk of subsequent events, and to lower risk of 5-year mortality by up to 45%. But for Bob, there's a challenge. So for Bob to go to cardiac rehab, he has to take time off of work, drive 45 minutes to get to clinic, and then pay a $50 copay every time he gets there. And this is simply not possible. Unfortunately, Bob's not alone. There are more than 2 million patients that are eligible for cardiac rehab every year, and less than 25% of them actually go. So what about digital tools, right? We're at a symposium on connected health after all. So to respond to this challenge, Wellframe has built a secure, scalable platform that combines mobile technology, artificial intelligence, and a supportive service to extend the provision of care from the hospital to home and to support patients like Bob who are going through programs of secondary prevention after discharge. We also use sensors on the phone, in this case the accelerometer, as a pedometer to track Bob's physical activity, which is a core component of a program like cardiac rehab. We ask Bob questions around biometric feedback and psychosocial assessments. All the while, we allow Bob's clinician, in this case a cardiac rehab nurse manager, to monitor how patients are progressing through the program and gain insight to help them understand patient risk and to guide the subsequent provision of care. We also enable two-way messaging so that Bob can get continuous feedback and guidance and support from his clinician, and then soon from his family and from peer patients. So the idea is really to help Bob feel like he's being cared for on a daily basis and given reinforcement both through the technology as well as in person when he comes back to the hospital. So that's nice, you might be asking, but does this actually work? We recently completed a pilot clinical trial at Brigham and Women's Hospital among patients enrolled in cardiac rehab, and this was facilitating a hybrid model of cardiac rehab where patients were still coming to clinic, but some of them much less often, and they were using our remote system to guide and support them in between. So the results of this pilot have been submitted for presentation at the National Cardiac Rehab Conference, and so instead of speaking to those results specifically, I'm going to talk more generally about the experience of patients in our system. So I think the main point and the first goal that we had is to give clinicians insight into what's happening among patients. We heard from the nurse managers in this clinic that before they really just didn't know what patients were doing in between visits. And now they have insight into the day-to-day of what patients are doing that they've never had before. The major driver of engagement here, or one of the major drivers of engagement, is that the clinician is actively involved in the process. So we've had over 1,500 patient touches through push messages, over 500 touches through one-way messages, and over 800 touches through two-way messages. And this is where the clinician can initiate a conversation and ask the patient for a response. As a result, the patient engagement's been quite positive. Over 80% of our patients are what we're calling engaged, and that's an arbitrary distinction, but this means they're doing more than half of their daily tasks. And they're checking in over twice a day, and 100% of the patients, including 80-year-olds, have said that it's easy to use. And that was really one of our first goals. So if we look at engagement over time, and this is among patients who've been on the system for a little over 9 weeks now, we started off around 90%, and we've leveled off around 80%. So, I think that one of the biggest concerns around mobile technology is that patients stop using them after a few days. the continuous interaction with the clinician really changes the psychology for patients, where they see this as an extension of their care, and it's really been a good driver of sustained engagement. If we take a look at physical activity, this is objectively tracked using an accelerometer and includes patients who are doing at least 30 minutes of activity a day, at least 4 days a week. You see that the engagement rate has gone from about 60% to about 40%. We started experimenting with allowing patients to self-report their activity as well. Some patients are doing activities that weren't conducive to using their mobile phones, were swimming, things like that, and this started going up to 60% plus. Now, with respect to medication adherence, we see that over half of the patients in our system are checking in for their medications at least 75% of the time, and over 80% of the patients are checking in at least 50% of the time. Now, as an epidemiologist, this is frustrating because there's no baseline, right? But that's kind of the point, that before we really had no clue. So this at least gives us a baseline and something to start iterating on a system and a service to start moving these numbers up. So we hear from patients, I think the two main feedback that we're focused on is that, number one, it helps to simplify the day-to-day of what they need to do, and number two, that it helps them feel connected. They feel like they're being cared for even when they're not in clinic. On the provider side, we've been very conscientious to make this quick, to make it easy, and to make it integrate into their workflow. So what's next? We have a phase 2 trial that we're preparing for, where we randomize and start to look at behavioral, biometric, clinical, financial outcomes, all the things that you'd be looking to see. We also have another trial coming up at an academic medical center in New York, where we're being used as an efficiency tool for case managers doing follow-up with patients after discharge across coronary heart disease, congestive heart failure, and COPD. So a bigger picture we really see as there's an increased focus on patient engagement in the transitions of care. Hospitals and health systems are staffing human resources to engage patients, but there's a natural limit in terms of what can be done in person and over the phone. And we're really trying to build a platform that serves as an efficiency tool to facilitate more effective, more efficient, and more intimate case management. Science.